Lung cancer is the most leading cause of death in oncology diseases. So we need new treatments to offer patients better treatments. With nintedanib, we have an option in combination with docetaxel in the second-line setting after failure of the first-line chemotherapy. And we are deciding if we are using this drug when the PD-L1 status is negative or lower and the tumor is progressing rapidly. After the first-line treatment, we offer patients in the second-line setting docetaxel plus nintedanib, an oral drug combined with a IV chemotherapy. Or when immunotherapy is used in second-line setting, we use the drug in the third-line setting. We, in our center, have experience with 150 patients, good experiences in terms of good a drug that has no heavy side effects. The side effects is coming from docetaxel. We're using it mainly with a different schedule, weekly schedule, combined with nintedanib orally. And when the chemotherapy is not accepted properly, we use it as a maintenance therapy alone. And normally this drug is accepted very good and has a good efficacy in special patients. Let's say 10 years ago, when I started in Berlin, in the Charité of Berlin, lung cancer was lung cancer. Now we know lung cancer is not lung cancer anymore, and we have to decide each treatment individually. So nintedanib is a puzzle in the whole treatment in second or third line setting, and we can increase the survival for more than 9 months in special patients. And that does not mean that everybody lives 9 months longer, but some patients live longer, some less. And in the whole puzzle that you offer then immunotherapy after third line, when you offer new other drugs too, in the whole puzzle the patient will survive longer than many years before. 6 months was the normal overall survival without any treatment. With 12 months is the average what we made now. Let's say 3 years ago, and now with the new drugs, targeted therapy, immunotherapy, angiogenic drug like nintedanib, we can put all these drugs together and decide what is the best for that patient, and we need each puzzle to offer this good survival to each patient. We have to be aware that palliative care is the most important thing. So we're not allowed to give patients a heavy treatment and they have no life quality. Therefore, this is the reason why we offer docetaxel in the weekly schedule to avoid heavy side effects. And if the side effects of docetaxel are very heavy, we just continue with nintedanib alone to have a good treatment and a good life quality, because nintedanib alone has a very good life quality. In Austria, in the beginning, we had the opportunity to use nintedanib in a named patient use program before it was labeled by the EMEA. So we made already experience 3 or 4 years ago with nintedanib. Also in studies, we used it, so we have an experience already from 3 or 4 years. The reimbursement started, I cannot tell you exactly, but 1.5 years ago. And it's after, in the second line setting, it gets reimbursed. After failure of the first-line treatment, platinum doublet, and progression, it's getting reimbursed. Especially we're using it in patients who have a fast progress to chemotherapy in second-line setting, or lower PD-L1 status, or no PD-L1 status, or use it in third-line setting, and it's paid by the insurance companies. In Austria, we are in a lucky position. We can offer the patients in the moment all registered drugs in terms of, for example, EGFR mutated patients can receive TKIs without any problem. Afatinib is no problem at all. Also in ALK inhibitors, we can offer patients crizotinib, ceritinib. We can offer PD-L1 immunotherapies without any problems with nivolumab and pembrolizumab. Even without any clinical trials, in daily routine, we can offer those drugs in our patients. And nintedanib is a part of this puzzle to offer these patients the best treatment.